Right. Hello, everyone. So fifth video, we're over halfway, well over halfway. So this one's basically about rhythms. So I'm just going to show you the PowerPoint here. So supraventricular and ventricular tachycardias especially. And so the outline is going to talk about supraventricular, so above the ventricle, or supraventricular tachycardias. So there's sinus, there's stuff from the AV nodes, that's what that AV stands for. There's multifocal atrial tachycardias, and there's also atrial flutter and AFib. And for ventricular tachycardia, there's torsades de pointes, tach, and ventricle fibrillation, and just making sure we cover each of the bases, and then practice. So just to show you briefly on this cheat sheet where we're going to be looking today. So we are going to be focusing on this rhythm part. So it's going to be this whole section, and yeah, so we'll be working through it, and then we'll do practice cases at the end. And of course, feel free to jump to the practice cases if you just want to see how you apply the information. Let's start. So this is a nice picture from Lily's that just kind of shows the supraventricular tachycardia, so coming from above the ventricles. And this is where recognizing the rhythms that you're seeing becomes important. So if it's in your regular rhythm, so the distance between each R wave is changing, then you're going to see either atrial fibrillation, where there's just like a wavy baseline, and it's all kind of muffled, or you're going to see greater than 3 P wave shapes, and that's called multifocal atrial tachycardia. And I think we actually talked potentially about this before. The other types are like sinus tachycardia, so you're going to have just normal P, QRS, T. Re-entrant supraventricular tachycardias, and there's some pictures showing these. And one of the things that really makes them stand out is the P wave is coming after the QRS, or it isn't visible. But the QRS will still be a normal width, which tells you that's coming from the Purkinje fibrous bundle of His. There's focal atrial tachycardia, we're not going to really talk about that one. And there's atrial flutter, which is sawtooth waves. And I'll have some pictures showing that. So sinus tachycardia, it's just like if you're running really hard. So you have the P, Q, R, S complex, and then the T, P, R, T, P, R, T, and so on and so forth. And it's greater than 100. Multifocal means there's 3 different P waves. You see there's this one type of P wave, there's another type, there's a third type, and this rate would be 300, 150, so over 100, so quite rapid. And you can notice the QRS is still narrow, so we know it's coming from above the ventricles. So you can just ignore the number here. This is just another picture showing the multifocal atrial tachycardia. So you can see there's one type of P wave, a second type, and a third type, and the rate is quite quick. But you can also see it's kind of near regular rhythm. So that's kind of telling you that something is off. And here's just a third picture just to, I guess, really drive home that multifocal atrial tachycardia. So it's an irregular rhythm, and then you're seeing a narrow QRS. You see R, it's like 1.5, 1.5, 2.5, 3.5. This one's 2, this one's 2.5. So it's changing. So it's irregularly irregular. And then you can see there's this P that's one shape and a different shape, different. And then you kind of go through that cycle. All right, so AV node re-entrant tachycardia, essentially what's happening is the signal's coming through from the atria, it's going through the AV node, and usually it's slightly delayed, and then it goes through the bundle of His and Purkinje fibers. However, if there's, say, a block in kind of this side of the node of this, so part of the circle, what happens is the impulse goes back around and actually fires back into the atria. So you get the P wave occurring after the QRS. And then it starts to loop. So this goes up and that triggers this part down, and it goes up and triggers. So you start to get a loop like this. So you get very fast rates, like over 200. And this is just another picture showing that. So with like Wolf, Parkinson, White, we could see that P, really short PR interval to the delta wave, and then there's the QRS complex, then the T. And that's because it's coming around. Well, with somebody with a bypass tract, it can start to loop around that bypass tract. So it could go, it could go in this like clockwise direction. It could go down through and then back up. you're getting retrograde P waves, or it could go counterclockwise. So the other way around. So it's going up through the atria and then down. So because it's not going through the bundle of His and Purkinje fibers, you get a very weird wide QRS and then the retrograde P waves. So what you're really looking for the most part, is this retrograde P waves in a very fast rate. And this is just another picture showing that in a larger scale. So you see the bypass tract, and it could be spinning around to the right. So using this file, is you're going to have a narrow QRS with the good fibers, and then you're going to have retrograde P. If you flip it around and you run the tract the other way, you're still going to have the retrograde P wave, but you're going to have a very wide QRS. So, and then this is the accessory pathways with Wolff Parkinson White. Just a quick review, just showing it's going around, and it can go around that path. And if it starts to loop, you get the AV-RT or AV-NRT, depends on what you're having. So quick note, just to differentiate them, AV-RT is going kind of around this bypass tract. AV-NRT, it's within the node and it's spinning around in the node. So that's how you tell those two apart. Physiologically, on the ECG, it's not quite as simple. They look very similar. So here we're seeing that this rate is really fast. So we see it's like, let's get one. So like 300, it's like over 150. So, and there might be some retrograde P waves. And the thing that stands out is there's no P wave before the QRS. However, the QRS is still narrow. So that should be kind of your signal thinking this might be AV node related. And similar idea, looking for those retrograde P waves with a narrow QRS. This is just a table you can review on your own. And this is a quick summary. So showing that image, and then this table is going to show each of the things that we just talked about for all those supraventricular tachycardias. So there's 5 of them there. You can just review them on your own time. Atrial flutter. So flutter has those sawtooth waves, and you've probably already seen this. This is probably just review. So, you know, P, 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 QRS, P, 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 QRS, and it looks like a saw. Atrial fibrillation would be baseline, QRS complex is intermittent, and very irregular rhythm. So if we went here to here, it's almost 3 boxes, here to here, almost 3, but this one's a little bit longer, and so on and so forth. So irregularly irregular. And this is a table just summarizing that. You can look through that in your own time. Ventricular tachycardia. So you're not going to see any P waves because the QRS is constantly going. So this is no longer above the ventricles, no longer supraventricular tachycardia. This is ventricular tachycardia, so just in the ventricles. The QRS is going to be basically going up and down just like this. It's almost all going to be in the same way. And it's going to have an extreme axis. So if you're looking at your thumb rules, so lead 1 would be pointing down, and lead AVF would also be pointing down. So 2 thumbs down, it's an extreme axis. Torsades de pointes is another type. So if they have a long QT interval, they can start to get this kind of spiral pattern. So it goes narrow and then wide, and then narrow and then wide. That's torsades. And ventricular fibrillation is basically just a bag of worms. Basically, there's no coordination. When they talk about early after depolarizations, they're talking about this part, so after the depolarization, and then in this kind of study phase where it's kind of causing a refractory period, it can fire again. So that'd be an early after depolarization. And that's kind of puts it at a risk for torsades de pointes. So you see narrow, and then it gets wider, and then narrower, and then wider. So this is just kind of highlighting that the QT interval can result, if there's an abnormality, then you're going to start to see some like the risk of torsades de pointes. So that's why we check QT interval when we're going through our intervals. Ventricular tachycardia. There is a few rules to be able to differentiate supraventricular tachycardia from ventricular tachycardia. And sometimes when we were talking about, let's just go back to it briefly. When we're talking about, say, this unusual where it's going up and then it's going through the opposite way through the ventricles, this is related to the AV nodes. This is, well, it's actually related to the bypass tract here. So this is going to cause a wide QRS, which we usually associate with the ventricles, but it's actually coming from above the ventricles. It's actually a supraventricular. So there's a few rules that you can use to help differentiate the two. And you probably don't have to know this per se for the test in instance, but you're probably going to have to know this if you ever want to, shadow cardiology, or if you're ever working in areas that you're going to have to use an ECG, which is plenty. So essentially with ventricular tachycardia, we're seeing that nice big wide QRS, and it's going up and down, up and down, up and down. And there's a couple of things that can occur. So one is a fusion beat, and one is a capture beat. So this is specific to ventricular tachycardia. So essentially how a fusion beat works is you have this kind of like up and down of ventricular tachycardia, and then essentially you kind of have a mix where you have the ventricle starts to go, but then suddenly you get like a normal QRS that's getting fired at the same time from the atrium, because the atria are still going to be contracting. So the atria's fire kind of coincides with the ventricle's abnormal firing. So you get an abnormal beat. So it kind of makes a little bit of a nicer QRS. It looks a little bit more tight, a little bit more pointy, as you can see here. However, it's still kind of missing that rhythm to it. It doesn't have that nice like PQRST. A capture beat on indifference is that you're going to have, you might potentially see, and probably will see this P wave, and then you're going to see a really nice QRS and T. So what you're looking for is if you see this kind of nice QRS suddenly kind of pop in, or a capture beat where the atria suddenly is able to take over the ventricles again, you're going to know it's coming from the ventricles, and it's now a supraventricular rhythm. And so I just have down here a little table comparing the two. So we can just ignore this first line for right now. But if it's a supraventricular tachycardia, and they both have a wide QRS, of course, if you see capture and fusion beats, it's probably ventricular. And if it's an extreme right axis, it's probably ventricular tachycardia. Perhaps a little specific, but there's just kind of the breakdown. Again, this is ventricular fibrillation now. So you can see it's completely disorganized, and it just looks like this is kind of like a wavy line. And so this is just kind of having the rules again for determining the origin of the rhythm. And so you can look through this on your own time. I believe I discussed it in an earlier video. So we're on to practice. So I'll quickly go over the ECG cheat sheet for the practice for this round, and then we'll go through the practice examples. So rhythm is really looking at the relationship between the P waves and the QRS complexes. You really want to notice that the P's are upright, which means that they're going to be an SA node origin. Regular rhythm is 60 to 100, which would be sinus. If it's 60 to 80, you can suspect atrial, especially if there's inverted P waves, indicating it's an ectopic atrial source. Bradycardia, 40 to 60, probably AV node or junctional, should still be normal, nice, tight QRS. 20 to 40 ventricular, it's going to be a very wide QRS. Inverted P waves with a short interval, considering atria, because the atria is firing like right there, so it's going to be going through. Maybe the AV node if it's a slower rhythm. And then there's also AV blocks, which I'm going to talk about in another lesson, so we're going to go by that for right now. Ectopic, if you're getting premature inverted or abnormal looking P waves, they just stand out. It's just not really a tachycardia, it's just like a weird beat. Ventricular, same idea. It's not tachycardia, it's just an irregular beat through the PQRST, and you can see it. Tachycardia greater than 100. If it's narrow, you're thinking supraventricular. Sinus, so that's the sinus SA node can be causing it, the atria can be causing it, or the AV node can be causing it. If it's sinus, the P wave and QRS are normal. AV, RT, AV, and RT, we're talking about the retrograde P wave. And then if it's wide, double check to see if there's any capture or fusion beats, then you know it's VTAC. A flutter, you know it, sawtooth waves. If it's monomorphic wide QRS and there's no P waves, you're thinking ventricular tachycardia. Double check if you see those capture and fusion beats and an extreme right axis, you nailed it. If it's irregular, so especially like irregularly irregular, so it's off, but it's not consistent in how it's off. It's like 4 boxes, 5 boxes, 4 boxes, 2 boxes. So multifocal atrial, so greater than 3 shapes. AFib, it's basically got no baseline, wavy baseline. And VFib, it's just going to be complete mess. So let's go to questions. So we have our, so I'll pull this up a little bit. I'll shrink this. All right, so let's do our rate. So we'll just kind of work through this. So not quite as clean to read. Looks like 300, 150, 175, looks like about 80. And 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 cycles. So it doesn't match up, which means that this is probably an 8-second reading. So it's 10 cycles over 8 seconds. And you can just calculate that for yourself. I'm just going to keep going here. Lead 1 and AVF are both pointing up, so we're good to go. Normal axis. So then we're going to be looking at rate axis, rhythm. So it looks like P, QRS, T, P, P. This one's a little bit abnormal. So this looks like it's a wide complex, and it's that QRS that's really wide. So this is probably a ventricular premature beat. So plus a ventricular premature beat. And then we kind of go back. So P, P, P. It looks like there's always a P and then QRST, so it looks like a sinus rhythm. So let's check our intervals. So P to R looks pretty regular. This guy's the exception. Yeah, it looks like it's within a box and not too far, not too close. So intervals, so normal PR, QRS looks nice and normal, except for, of course, that large one there. So I'm going to say number QRS, and then we can just add that one ventricular premature beat there. And then QT is less than half. Yeah, it looks like less than half. So we're just going to say that's a normal QT. All right, so our first sentence is done, looking for hypertrophies. So left atrial enlargement. Yeah, it looks like there's a left atrial enlargement. You can see this is not especially big, but this is inverted and it looks like a decent size. So left atrial enlargement. And then checking for left ventricular hypertrophy, that looks like the case. 1, 2, 3, 4, about 5. And this is definitely enough. Well, about 1, 2, 3, 4, 5. Yeah, it's well over enough. So left ventricular hypertrophy and right ventricular, no, because we have S waves to R waves. Okay, so now we're going to check for bundle branch blocks. So this QRS was definitely wide. And this one looks nice and narrow. It looks, yeah, this one's definitely narrow. And it looks fairly narrow. So most likely we're not going to be seeing a bundle branch block here. So no bundle branch blocks. All right, so now we're going to go through our kind of scheme for Q waves as T segments, T waves. So let's start with the lateral, and then I'm going to have a piece of paper. Actually, I'll draw it on the computer so you can see it. So checking lateral for Q waves, there's no Qs in 1. Don't see any Qs in ABL, and I can check over in V5 and V6 to make sure. Doesn't look like we have Q waves. So no Qs left. It's lateral actually. It's lateral. No Qs. ST segment. It's pretty close. It looks like on this side of the baseline and on this side of the baseline, that line is almost crossing the same spot. And over here, it's mostly the same. And this really throws it off. So I'm just going to leave it at that. V5 though. Yeah, it looks like that's depressed. You can just see this baseline is to that baseline is definitely lower, and V6 without question. So V5 and I'll come back to V5 and 6. I'll actually put them down here. V5, 6. So depressed. ST segment. And actually, so let's put that there. And let's check for the T wave. So T wave is inverted, and this T wave, probably normal, but these two T waves are inverted. So T is inverted. 1, V5, V6. And now that I'm kind of getting suspicious, I might actually even be thinking, if it's a depression in one, it's there, it's a little bit, but it's very minor. So I'll kind of just leave it at that. And now let's check inferior. So checking for Qs, no Qs. Checking for ST segments, maybe a little higher, but not, probably not. Yeah. This looks pretty similar. So I'm going to say no ST changes. And then my T waves looks normal. Okay, so V1 to 2. This ST is a little higher. So is this one. Those are Q waves, I think. I don't see an R at the start. So let's start with the Qs. So Qs present. Yeah, that looks like Q waves. Unless that tiny blip is my R wave. It looks like a Q to me. So, and then I think this is a slight ST elevation in V1 and V2. And it looks like I'm just going to add in V3 here because V4 looks pretty similar. So it looks like V1 through 3, V1 through 3 ST elevation. And the T waves in 1 and 2 look normal. So normal T's. And then V3, V4, I'm just going to see above because I'm kind of recording both at the same time with that. Yeah, I'd say it's pretty similar throughout. Then V5 and V6, we have in that lateral segment. So the only other thing we need to comment on is R wave progression. So there's a Q, looks like a Q, Q, a massive Q. Maybe it's an S. Maybe. It might be S because we had left ventricular hypertrophy. That looks like just like a Q, and then R and R. So R wave progression is abnormal because it should be kind of coming up around here. We should be seeing an R wave, and we don't. So it looks like we're going to need to interpret that. So interpretation. So it looks like we have. Let's start with the Qs. So Q waves V1 through 4. And we have ST segments, so depressed lateral ST, so V5 and 6, T inverted in 1, D5 and 6. And just going to put the elevated in here, so V1 through 3 ST elevation. So that's my interpretation of what we just saw. So I'm going to take that, put that above so I can have it nice and neat. And then let's have a look at the solution. All right, so I had rate is 80, so that's the same. I had a sinus rhythm, so normal sinus rhythm with a preventricular beat complex. Yeah, have that. Normal axis, agreed. Intervals, normal, normal, normal. Yeah, same. I had left atrial enlargement for that inverted P wave. Doesn't look like they have it here, but they didn't comment on it either. Left ventricular hypertrophy, yes. I know about a branch block, they didn't say anything, so yeah. All right, and so interpretation. So I was thinking Q waves, and they have question mark septal Q waves, so 1 through 4, that makes sense. V1 through 3 ST elevation, V1 to 3 ST depression and lateral, ST depression and T inversion. Yeah, V5, 6, 1, and the AVL is kind of hard to read because it's got that PVC, but they say it's there, so 1 there as well. So include the AVL, and that ST depression is very subtle in the lead 1. You can kind of make it out. So One of the things I didn't really comment on was left ventricular hypertrophy with strain. So we can attribute this V1 to 3 ST elevation. It also has with, as you're noticing, it's got the convex shape. So it's got a convex T. I mean, I missed that myself. So with the convex T, so then we're thinking strain. Okay. And here's just a little picture, just also showing this is the QRS, this is the ST elevated, and then this would be like a flat T segment. So this would be like pathologic for MI, as opposed to if it was like curved, that would be like strain. So if it had a nice happy face in here, or hockey stick. Question 6, let's do this. Rate, fast, very fast, like almost 300, or not 300, but just under it. It's really fast. And I just remember that this is an 8-second ECG, so you can count them. I think it's about 28 cycles. Anyways, it's really fast. It's way over 200. So if it's way over 200, we're not thinking SA node anymore, because that's just way too rapid. So that's probably some kind of like tract spinning around in the AV node axis. Up, so normal axis. Rhythm, fast, obviously. So if we're thinking it's over 200 and it's got a narrow QRS, we're thinking, so right away we should be thinking supraventricular tachycardia. Now the question is it the atria, is it the SA node, or is it the bypass tract of some kind, AVRT, AVNRT? So it's got to be something in there. So if we look at this, we're now trying to figure out where are the P waves. If we can see P waves, then it directs us one way or another. So that looks like a T, and there's a little blip down here. So it goes QRS, and there's this blip, and then it goes up. So the kind of question is that like right there? I mean, this is really small. It looks like there's this little blip right here. There's another one there, and there, and there. So these look like retrograde P waves, and then the T wave is going up. So if we have retrograde P waves, so that probably is AVRT or AVNRT. We don't know if it's a bypass tract or if it's an AV node spinning around, but it's one of the two. All right, and then intervals. Well, the PR is shock, so NA. The QRS is narrow, so that's how we know the rhythm. And then the QT is, it's greater than half, but they're in tachycardia, so normal. Hypertrophies. It's going to be tricky to read any atrial, so I'm just going to skip atrial because I could look for it, but if it's got that bypass tract spinning, then it's going to be almost hard. It's going to be almost impossible to use our criteria because it's already abnormal. And then ventricular, this looks like left ventricular because it goes like, we look at this one, 1, 2, 3 about, and this is huge. Look at this. This is like 1, 2, 3, 4, 5, 6. That's well past what we need, providing I'm reading the graph right. So I think it's a left ventricular hypertrophy. All right. So what else do we want? Hypertrophy. Okay, so we can check for bundle branch blocks, but they're not going to be there because it's a narrow QRS. So now we're going to have to go through our Q, ST, T, and R waves. So let's start with the lateral. So lateral, looking for Qs. Nothing notable, so no Qs. Let's check V5 and V6 to make sure. V5 and V6. No Qs. All right, ST segment, depressed for sure. That's depressed. V5 and V6, depressed and depressed. Yeah, so I'm going to say ST depression. V5, 6. And also V1 and AVL. Okay, no Q's, ST depression. Let's take the T wave inverted. Hard to say. It doesn't look inverted there. No, that looks normal. So I'm going to say inverted in lead 1 and AVL. So that doesn't really tell me a whole lot that T's being inverted. It tells me that there is an abnormality, but it's kind of expected. The heart's beating over 200 beats per minute. So let's just keep going with inferior leads. Q, no Q. All right, good for Qs, no Qs. ST, depressed. Looks, yeah, it's ST depression there. And you can look at the baseline here, baseline there, that's ST depression. So ST depression. And the T's are up, up, up. So normal T's. All right, now let's go through our precordials. So precordials. So Q. It looks like there's a little R before that one. This one looks like it has an R, so there's no Q's. And let's take these next guys. No, it's got an R, that's got an R. So no Q's. ST changes. Looks like this could be elevated here. This is like the easiest one to look at. It doesn't look especially noteworthy. Maybe depressed actually, just based on how it's kind of coming out and then around. And then V2, this one looks definitely like ST depression, depression. That looks like depression. So depression, V1 through 6, which we already mentioned earlier, kind of with V5 and V6. And then T waves. Up, 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 up. Okay, normal T's. So interpretation. So the interpretation looks like there's no Q's. There's diffuse ST depression. So we've got V1 through 6, 1 in AVL. Oh, and inferior. So 2, 3 AVF. So basically almost everything. And then inverted T's, lead 1 and AVL. And then if we kind of take that interpretation and apply it to the rest of our information we got, looks like that ST depression, it could be related to this insane tachycardia, or it could be also perhaps related to left ventricular hypertrophy. Kind of depends. Let's have a look at the solution. Okay, so rate greater than 200 for sure, 29 cycles, so 220 beats on 8 seconds. Axis is normal, no clear P's, we talked about that. And rhythm, SVT, because it's narrow QRS, is so fast. And because there's retrograde P waves, I think I was like looking down here when I saw them, and it looks like he's kind of pointing some out over here. Retrograde P's and inferior leads. So yeah, retrograde P waves, AV NRT or AVRT. So you just queried it. Intervals, PR. There's no clear PR, obviously. QRS narrow, yeah. QT is greater than half, but it's tacky. They have no left ventricular hypertrophy, right ventricular hypertrophy. So perhaps because of the change in rhythm, it looks like it's over the 7-box criteria, but perhaps it's also just the quality of the graph. And interpretation. It looks like I had said no Q's, diffuse ST depression. Yeah, they said that. I inverted T's in lead 1 AVL, and they said inverted T's laterally. So that was a good interpretation. All right, question 7. So let's do the rate. So 300, 150, 100, 75. Looks about 75, and probably an 8-second ECG. Let's double check. 1, 2, 3, 4, 5, 6, 7, 8, 9, 9, 54. Yeah, it's 8-second ECG. Axis. Up, and that's down. That's pre-isoelectric, so we're going to say left axis. Rhythm. Look at all those. That is definitely a fibrillation. That's flutter. Yeah, it looks like flutter. So rhythm, flutter, atrial flutter, just to be clear. Intervals. There's not really any PR interval just because of how this is working, but we can count the ratio. So 1, 2, 3 QRS. Over here, 1, 2, 3 QRS. Maybe this guy 1, 2, 3 QRS. So there's 4-to-1 ratio because essentially you go 1, 2, 3, and this would actually be the fourth, but the QRS is occurring on that 1, 2, 3. This is the fourth. QRS is occurring. So every 4 P waves, there is a V wave or a ventricular contraction. So 4-to-1 atrial flutter, and then QRS narrow, and then T looks like less than half, so normal T or QT. All right. So hypertrophy, it's going to be hard to read any atrials. So skip atrial, ventricular. All right, let's just get back to this. So checking ventricular hypertrophy. Doesn't look like there's any left and doesn't look like there's any right. So no hypertrophy. Where are the intervals? Bundle branch, no. And then checking our lateral leads. So we're going through our QRS and whatnot. So lateral. No Q, no Q, no Q, no Q. ST. Oh, over here. Nothing like it, no. Looks pretty normal. Let's see. Checking our T waves. Up, flat, maybe a little bit up, up. So I'm going to see normal T's because it's not reciprocated in 2 beats, so probably not significant. Inferior. Checking Q's, no Q. There's a Q, no Q there. So just going to say no Q's, needs to be at least 2 beats. ST. Pretty normal looking. So normal ST. T waves, up, 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 good, normal T's, and then precordial. So sometimes I group the precordials just to be a little bit quicker, but if it starts getting a little bit more specific, like I see V1 and V2 are not the same as 3 and 4 and 5 and 6, then I'll try to separate them out. And then I like to do the precordials as a whole section as well, because I'm checking that R wave progression at the end. So if it's not there, then I'm thinking that there's a Q wave and that's an anterior infarct. So checking Q's. Potentially Q, no, normal, so probably no Qs. Normal R wave progression. ST, flat. And the ST looks pretty good, so normal ST. And then T waves, probably normal, up, yes, good. Normal T is interpretation, nothing. Yeah, nothing significant. So we're going to take this and we're going to take it over to the next page. Let's see what we did. So rate 75, yes, bingo. Multiple P's, yeah, we talked about that. We didn't talk about the axis though here yet. Sawtooth inferior leads, so atrial flutter 4-to-1. Atrial flutter interval, yeah, we said 4-to-1. Axis -30 leftward, so left axis, got it. No PR, normal QRS, normal QT, yeah. No hypertrophies, got it. No pathological Qs, yeah. No ST, elevation or depression, yeah. Normal Ts. So our interpretation was correct, nothing significant there. Question 8. So another 8-second reading on ECG, probably 300, 150, 100, so just under 100. So no, it's less than 100, but it's irregular. And it's irregularly irregular because it kind of has, this is like a normal, but then there's this big space, and this big space was over here. So, and this looks a little bit different in space. So irregular. So irregularly irregular. It's kind of more of a rhythm thing, but you can do it there too. 1, AVF, normal axis. Rhythm. Well, we're looking for P waves, and I don't see any P waves in here. No P's. Not very clear. This is just kind of weird. It just, and this one, B1, it looks all kind of wavy. So the rhythm, irregular, irregular, really hard to see P waves. It's probably atrial fibrillation. Intervals. Well, the PR is NA. QRS is narrow. QT is normal. It's less than half. Hypertrophies. Not going to be able to read the atrial, and left looks normal, right looks normal, so no hypertrophy. Okay, running through our bundle branch. No, definitely not. Now checking the laterals. No Qs, no Qs, no Qs, no Qs, no Qs. Checking our STs. Looks normal. Yeah, normal. Good. Yeah, no ST changes. T waves. Normal. Normal. Normal, normal. Normal. Okay, now let's check inferior. Inferior. Don't see Q, no Q, no Q, so no Qs. I didn't see any ST changes. And it looks like, well, there's a T. That may be a T, it's pretty flat. This almost doesn't. So maybe flat T's / normal. Kind of have to keep going to see if that means anything. And then precordial. Let's take a look. No, there's an R there, so no Q, no Q, no Q, no Q, no Q, so no Qs. ST, flat, flat, flat. Good, good, good. So just looking across, it looks the same on both sides of the QRS for that baseline, so there's no ST changes. And then the T's, normal, 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 normal. This one looks kind of flat, but it's only one, so I'm just going to say normal T's. So interpretation, nothing significant. Okay, so let's take this and have a look at the next page. Axis, or this should be my rate. Rate. Okay, rate less than 100. Yeah, it's less than 100. So 11 cycles, it's regular, irregular. That's the big thing to get. No clear P's. Yeah, we were talking about that. Normal axis, bingo. No PR, but there's normal QRS, no normal QRS, normal QT. No hypertrophy, got it. No pathological Qs, yeah. No ST elevation depression. Flat T's inferiorly. So we said nothing really especially significant in our interpretation, and it looks that way aside from AFib. Okay. Question 17. So we don't have a full leads axis here, but this is, you can see it's going up, it gets narrower, and then it kind of goes back to normal. Anyways, this is probably torsades to points. It's going up and down. Yeah, ventricular, wide morphologies, polymorphic. It's probably torsades. Got it. And this is just VTAC, and then we can check the axis. So you just look for one that has a nice, obvious, this is the contractions. I like AVL here. This looks like systole or R. So this is the R, this is the R. So if I go up, this one is actually inverted. So lead one is inverted, so it's thumbs down on lead one. And if I go here and I go down to AVF, it's actually also going down. So it's thumbs down in both, extreme axis to the right. And it's VTAC, obviously. So I didn't bother reading the rate, but the rate's high. No clear P's, there's an extreme axis, we got that. Wide QRS, yeah, got it. So it's ventricular tachycardia. So hopefully that makes sense. And that's all for today. Thanks.